Good day, and welcome again to Learning Pharmacology with me, Nurse Myron. For today's learning activity, we will be discussing antihypertensives. For our full disclosure, I am not affiliated with any of the manufacturers of the drugs or other items mentioned in this lecture. The mention of such brand names are only in passing and for educational purposes only, and are not for commercial promotion. I have no actual or potential conflict of interest in relation to this presentation. So let us begin with a review of the anatomy and physiology of the heart, the circulatory system, and blood pressure. The heart is the organ responsible for pumping blood all over the systemic circulation throughout the body. Blood enters through the superior and inferior vena cava to the right atrium, passing through the tricuspid valve into the right ventricle. It enters the pulmonary valve to the pulmonary artery where it enters the pulmonary circulation, where the blood gets oxygenated. From the lungs, the blood returns via the pulmonary vein into the left atrium, then the mitral valve, then finally to the left ventricle, before it is pumped out through the aortic valve into the aorta through the systemic circulation. Blood pressure is defined as the force or tension of blood pressing against the walls of the arteries. It is normally measured by two digits: your systolic BP, or the pressure when the left ventricle contracts, also known as your systole, and your diastolic blood pressure, known as the pressure between contractions, or diastole. There are many factors that affect the person's blood pressure, including contraction of the left ventricle, elasticity of the peripheral blood vessels, systemic vascular resistance, and blood volume. Rapid control of blood pressure lies on baroreceptors. These are pressure-sensitive neurons found in the aortic arc and the carotid sinuses. An increase in pressure detected by these baroreceptors increases baroreceptor firing. A signal is sent via the cranial nerve number 9, or glossopharyngeal nerve, to the brain, where it sends a signal. Then, a signal is sent via cranial nerve number 10, or the vagus nerve, to initiate the parasympathetic response, where the heart will adjust in decreasing the heart rate and thus the cardiac output, leading to a decrease in the blood pressure. On the other hand, a decrease in pressure detected by baroreceptors also results in decreased baroreceptor firing. This initiates a signal to be sent to the adrenal medulla, where the adrenal medulla releases catecholamines such as your norepinephrine, epinephrine, and dopamine. These chemicals initiate the sympathetic response by triggering the alpha and beta receptors. This increases cardiac output and systemic vascular resistance. The heart adjusts, and there is an increase in the heart rate and consequently an increase in the blood pressure. Likewise, the decreased baroreceptor firing can cause decreased vagal activity. This leads to an increased cardiac output, which also leads to increased heart rate and an increased blood pressure. On the other hand, for long-term control of blood pressure, the body has the renin-angiotensin-aldosterone system, also known as the RAAS. Here, the chemical angiotensinogen is produced in the liver. It enters the blood, and when it comes in contact with a chemical known as renin, produced by the kidneys, it is converted into angiotensin 1. Angiotensin-converting enzyme produced by the lungs converts angiotensin 1 into angiotensin 2. Angiotensin is a very potent chemical. It acts on blood vessels by promoting vasoconstriction of all blood vessels. It acts on all smooth muscles. Likewise, angiotensin II acts on the adrenal gland to stimulate the release of aldosterone. When aldosterone is released, it stimulates the reabsorption of sodium and water. The net effect is an increase in the blood pressure of the patient. To treat hypertension, we have a wide variety of antihypertensive medications available in the market. These are the classification of antihypertensive drugs that are given to patients, including your adrenergic antagonists, alpha-1 and beta blockers, centrally acting adrenergic drugs, calcium channel blockers, angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, vasodilators, and a group of drugs known as your diuretics, which we will be discussing separately. First, we have your adrenergic antagonists, alpha-1 blockers. Recall from our discussion on adrenergic drugs the different adrenergic receptors, namely your alpha-1 found in the smooth muscles, especially of the blood vessels, beta-1 primarily found in the heart, and beta-2 receptors primarily found in the airways in the lungs. When stimulated, alpha-1 receptors cause vasoconstriction, beta-1 causes an increased heart rate, and beta-2 produces bronchodilation. Adrenergic antagonists include your alpha-1 blockers. These drugs selectively block alpha-1 adrenergic receptors, primarily located in vascular smooth muscles. Blocking these receptors prevents norepinephrine from binding, thereby resulting in relaxation of arteries and veins, causing vasodilation and a decrease in peripheral vascular resistance, thereby leading to a decrease in blood pressure. Because venous dilation reduces venous return or preload, these drugs are also responsible in reducing cardiac workload. Examples of these drugs include doxazosine, prazosin, phentolamine, terazosine, and urapidil, the latter being available so far only in Europe. These drugs are indicated for hypertension and are often used in combination therapy. Sometimes, some of these drugs are also indicated for benign prostatic hyperplasia or BPH due to their ability to relax smooth muscle in the bladder, neck, and prostate. Caution should be advised when giving these drugs because of the possible side effects including orthostatic hypotension, especially with the initial doses, dizziness, headache, palpitations, edema, and fatigue. Therefore, as nurses, patients should be instructed to take the first dose as bedside to reduce the risk of orthostatic hypotension and syncope. Patients should also be taught to rise slowly from sitting or lying positions to avoid sudden dizziness. Blood pressure monitoring should be done regularly. The patient should also assess for peripheral edema and other signs of fluid retention. Next, we have your adrenergic antagonists, your beta-1 blockers. Using this graphic, we can recall that beta-1 receptors are often found in the heart and in the blood vessels. When stimulated, it triggers the sympathetic response, where heart rate increases and contractions also increase. Meanwhile, vasoconstriction happens in the blood vessels. These result in an increase in blood pressure. Beta blockers reduce blood pressure primarily by blocking the effects of epinephrine and norepinephrine on these beta-adrenergic receptors in the heart and blood vessels. They decrease heart rate, cardiac output, and inhibit renin release from the kidneys. There are two main types of these beta blockers. First, we have your selective beta-1 blockers. These drugs primarily block beta-1 receptors in the heart while sparing beta-2 receptors in the lungs and peripheral vessels. Examples include your atenolol under the brand name Therablock, Tenorvas or Tenormin, bisoprolol under the brand name Biscor, the popular drug metoprolol under the brand name Neoblock, esmolol under the brand name Breviblock, and an oral tablet and also available in oral form or eye drops, your betaxolol. Meanwhile, non-selective beta blockers block both beta-1 receptors primarily found in the heart and your beta-2 receptors, usually found in the lungs and in the blood vessels. Examples of these non-selective beta blockers include carvedilol under the brand name Scoreg, Carvid, and Betadol, nebivolol under the brand name Bistolic, pindolol under the brand name Visken, and the popular drug propranolol under the brand name Inderal. Non-selective beta blockers are useful for hypertension, angina, arrhythmias, migraine prophylaxis, and essential tremors. Side effects to watch out include bradycardia, fatigue, hypotension, and cold extremities. These drugs should be avoided for patients with asthma and COPD because it can cause bronchoconstriction. Next, we have your centrally acting adrenergic drugs. Centrally acting adrenergic drugs act on the central nervous system, specifically on alpha-2 adrenergic receptors and imidazoline receptors in the brainstem. Activation of these receptors reduces sympathetic nervous system outflow, resulting in decreased heart rate, decreased cardiac output, and lower peripheral vascular resistance, all resulting in lower blood pressure. These drugs also increase parasympathetic or vagal tone. The most popular centrally adrenergic drug is your clonidine, under the brand name Catapres. Clonidine is indicated for hypertension, especially in resistant cases or in specific populations. Sometimes, clonidine is used for symptom management in opioid withdrawal and other conditions. Clonidine is available in tablet form and in IV. The tablet form is the drug of choice to immediately lower the blood pressure of patients in hypertensive emergencies. It is given under the tongue or sublingually with an interval of 15 minutes. The next category of antihypertensives is your calcium channel blockers. These drugs act by inhibiting calcium ion influx into vascular smooth muscle and myocardium, causing vasodilation, lowered myocardial contractility, and slowed conduction through the AV node. Under normal circumstances, when calcium ion enters the cell, it acts on the smooth muscle cells of the arteries to stimulate vasoconstriction. Likewise, calcium ion acts on the cardiac muscle cells to increase cardiac contractility. Calcium also increases electrical activity of the heart to increase heart rate. And lastly, calcium ions signal on the adrenal cortex cells to increase aldosterone production, leading to further increase in the blood pressure of the patient. The total effect is an increase in the BP through these mechanisms. When calcium channel blockers are given to the patient, the calcium channel is essentially blocked. Therefore, no calcium ions can enter the cell, and the mechanism that stimulates vasoconstriction, increased cardiac contractility, increased heart rate, and aldosterone are all prevented, thereby resulting in vasodilation, a decrease in cardiac contractility or a return to normal, a decrease or a return to normal in the heart rate, and the stop of the release of aldosterone. Calcium channel blockers can be divided into dihydropyridine and non-dihydropyridine calcium channel blockers. Dihydropyridines work only with the peripheral arteries. Thus, it promotes peripheral vasodilation. On the other hand, non-dihydropyridines work both in peripheral arteries and on the heart. It is easy to remember your dihydropyridines because they all end with dipene. For example, amlodipine under the brand name Norvasc, nifedipine, your calciblock, felodipine, Plendil, nicardipine under the brand name Cardipine or Nicardine, and your nimodipine under the brand name Nimotoc. Presently, there are only two popular non-dihydropyridine calcium channel blockers, and they are quite easy to remember. First, we have your diltiazem under the brand name Dilzem, Angiozem or Cardizem, and your verapamil, popularly known under the brand name Isoptine. Both these drugs are indicated for hypertension, angina, and certain arrhythmias. However, calcium channel blockers are contraindicated for patients with allergy, heart blocks, severe hypotension, or for pregnant women. Nursing considerations include closely monitoring the blood pressure and heart rate of the patient, assessing for edema and GI side effects, and encouraging patients to avoid grapefruit because of their interaction with calcium channel blockers. Side effects include peripheral edema, which is usually dose-dependent. By reducing the dose or combining calcium channel blockers with an ACE inhibitor, for example, amlodipine with your benazepril, this can be prevented. Nursing action for edema includes elevating the legs and wearing compression stockings. Other side effects include headache, flushing, dizziness, and lightheadedness. Special precautions should be observed by not giving these drugs to patients with heart failure because of the risk of fluid overload. Likewise, non-dihydropyridine calcium channel blockers are not to be given for patients during bradycardic episodes. Next, we have your ACE inhibitors. Recall in the renin-angiotensin-aldosterone system that ACE is a chemical produced in the lungs and is actually an enzyme that converts angiotensin 1 to angiotensin 2. ACE inhibitors, from the name alone, inhibits ACE in the lungs. It prevents the conversion of angiotensin 1 to angiotensin 2. When this pathway is prevented, it results in vasodilation and a decrease in blood volume through a reduced sodium and water retention, leading to lower blood pressure. It is easy to remember your ACE inhibitors because they all end with pril. For example, captopril, enalapril, lisinopril, perindopril, moexipril, quinapril, ramipril, and benazepril. These drugs are indicated for hypertension, heart failure, left ventricular dysfunction, and even diabetic nephropathy. However, contraindications include allergy to the drug, renal impairment, hyponatremia, hypovolemia, and pregnancy. It is best to administer ACE inhibitors on an empty stomach, usually 1 or 2 hours before and after meals. Likewise, monitoring of renal and liver function is necessary. Patients should be advised to report any persistent cough or swelling. Aside from maintenance medications, patient teaching includes changes in the lifestyle, such as modifications in diet, exercise, and weight control. Next, we have your angiotensin receptor blockers, or your ARBs. To better understand these drugs, recall that in our RAAS, that angiotensin receptors, when stimulated, triggers angiotensin II and aldosterone release, which increases blood pressure of the patient. By blocking angiotensin II receptors on blood vessels and adrenal glands, we can prevent vasoconstriction and aldosterone release. It is also easy to remember your angiotensin receptor blockers because they all end with sartan. For example, candesartan, eprosartan, irbesartan, the popular losartan, olmesartan, telmisartan, and valsartan. These drugs are generally safe and can be given with or without food. However, adverse effects include dizziness, headache, hyperkalemia, and fatigue. They are contraindicated for patients with allergy to these drugs or for those who are pregnant and with the hepatic and renal impairment. Our last group of antihypertensives include your vasodilators. These drugs act directly on the artery's smooth muscle. Vasodilators relax the walls of these blood vessels so that blood can move more easily. These drugs are used only in extreme cases of hypertensive emergencies or when other drugs have failed. Thus, vasodilators are given rarely. Examples of your vasodilators include your sodium nitroprusside or nitropres. Also, you have your hydralazine, like hylazine and hyperzine, and their derivatives, including dihydralazine under the brand name Neprasol, and cadralazine under the brand name Cadral. I hope that you learned a lot about the different antihypertensive medications that we have discussed today. Thank you for listening and continue enjoying learning.